Let's continue with part 2 of this lecture, the larynx. First, let's describe what are the functions of the larynx, and here they are. The larynx functions as an open valve during respiration, functions as a partially closed valve during phonation, and acts as a sphincter during swallowing or deglutition. The objectives of the lecture are these. At the completion of the lecture, you should be able to describe the skeleton of the larynx, that is, the cartilages, the spaces created by these cartilages, the nerves of the larynx, and the muscles that allow the functions of the larynx to be performed. Let's start. On the left, we see a cross-section of the neck. The drawing indicates approximately the level at C4, and on the right, we see a sagittal section of the head and neck. Let's add labels to become familiar with the area. The larynx extends from the root of the tongue to the trachea. For purposes of anesthesia, the larynx sits anterior to the esophagus. When intubating patients, novices may sometimes intubate the esophagus by mistake. Not a problem if you recognize your mistake. Pull the tube back and try again. Lateral to the larynx are the two carotid sheaths. Anteriorly to the larynx, it is covered by strap muscles, fascia, and skin. Finally, the size of the larynx is a function of age. The reason for this is that the larynx is an androgen-responsive tissue, and at puberty, the larynx in men begins to grow. Vocal cords become longer, and a man's voice deepens. I should mention two stories from history in which the lengthening of the cords by androgens, or absence of lengthening, played a role. First, during the 1976 Olympics, the highly touted U.S. female swimmers were overwhelmed by the East German women's team. I think the latter won almost all the events, including the U.S. strengths, the relay events. Days earlier, the U.S. women had run out of the female bathrooms because they claimed they could hear men. It was later proven that the East German team doctors had systematically administered steroids to their athletes, albeit without the athletes' knowledge. Not only had the East German women developed more muscle mass, but their vocal cords had grown and their voices had become indistinguishable from those of men. However, this is not the same as in the condition of androgen insensitivity syndrome. Androgen levels in these individuals are high, and also a celebrated Spanish Olympian was found to be androgen insensitive and she was disqualified. But in this case, the individuals cannot respond to the androgens because their receptors are defective. They gain no added advantage from the high androgens. The second is the history of castratis or castratas, depending on whether you're Northern or Southern European. Farinelli, a celebrated 18th century opera singer, is perhaps the best known among the castratis, and a Hollywood movie was even made about its life. No one knows when the practice started, but for centuries it has been customary to castrate poor boys with singing talent prior to reaching the age of puberty, and they acquire the characteristics of eunuchs. That is, they kept their vocal range of a child, yet the lung capacity of an adult. Their voices were described as otherworldly. The last castrati was Moreschi, and he died in 1922. You can hear him in the TED Talk cited here in YouTube by Brianna Robertson Kirkland, and indeed, the vocal qualities of Moreschi may surprise you. Not sure it can be imitated by current human opera singers. Let's start now looking at the skeleton of the larynx. Here, we see the skeleton of the larynx from the front and from behind. We start by identifying the hyoid bone. Technically, the hyoid bone is not part of the larynx, and is certainly not a cartilage, but because it is connected to the larynx by a membrane, anytime it moves, the larynx moves. Thus, we include the description of the hyoid bone when we discuss the larynx. Next, we mention the epiglottis, the leaf-like cartilage that forms the upper reaches of the larynx. We observe next the thyroid cartilage, ancient Greek for shield, and it does resemble a shield. Where the two lamina of the thyroid cartilage meet, it is known as the laryngeal prominence, or Adam's apple. The Adam's apple begins to grow at puberty under the influence of androgens. You may recall that women too make androgens, but that is converted almost as quickly to estrogens by aromatization enzymes. If it were not, women too will develop a larger larynx as the East German female swimmers did in the early 1970s. Below the thyroid cartilage, we have the cricoid cartilage. A cricoid cartilage resembles a signet ring, where one lamina is wider on one side than the other. Sitting on top of the wide lamina of the cricoid cartilage are the arytenoid cartilages. They resemble inverted drinking cups, and that is what arytenoid means. On top of the arytenoids are the corniculate ligaments, the two horns. Finally, if you really want to know anatomical trivia, the tritissial cartilages sit on top of the thyroid cartilages. I don't know what they really do, but otolaryngologists always ask the students if they have heard of these. At the start of this section, I mentioned that if the hyoid bone moves, the larynx moves. So let me remind you what moves the hyoid bone. Here we see the hyoid bone, and remember that it serves as an important attachment focus for muscles. What are these? Between the mandible and the hyoid bone, we had the hyoglossus, mylohyoid, geniohyoid, and the anterior belly of the digastric. Between the sternum and shoulder, we had strap muscles, the omohyoid, sternohyoid, sternothyroid, and thyrohyoid. From the pharynx, we had the middle constrictors. And finally, from the styloid and temporal bone, we had the stylohyoid muscle and ligament and the posterior belly of the digastric. So you see, the movement of the hyoid bone is integral to the movement of the larynx because the hyoid bone is connected to the thyroid cartilage by the thyrohyoid membrane. In addition to the thyroid membrane, we have the quadrangular membrane, and its free edge represents a false vocal cord. The third membrane is the triangular membrane. Its free superior edge is a true vocal cord, and please understand that the triangular membrane is not flush from the upper edge of the cricothyroid ligament to the underside of the thyroid lamina. Rather, the triangular ligament slides like a sheet behind the thyroid lamina to render a free edge, the true vocal cord. We now look at the spaces that are evident within the larynx. First, we enter the vestibule, the area just posterior to the epiglottis cartilage. Next, we see the slit between the true vocal cords. This is called the rima glottitis. Between the false and true vocal cords, there is a sinus or ventricle. Finally, below the vocal cords is located the subglottic space. Before moving on to the muscles, it is much more straightforward to describe the nerves. Sensory innervation above the vocal cords is by the internal laryngeal nerve, a branch of the superior laryngeal, in turn a branch from the vagus. From the superior laryngeal, we also have the external laryngeal nerve, which is motor to only one muscle, the cricothyroid. Sensory below the vocal cords is by the recurrent laryngeal nerves, and also the recurrent laryngeal nerves together do all the muscles of the larynx except the cricothyroid. We now move to the muscles of the larynx, And at the outset, let me say the names will be overwhelming because they're new to you. But as with the strap muscles, they're logically named. If you know the cartilages, the names of the muscles will follow. Let's start with the cricothyroid. It stretches from the surface of the cricoid to the inferior border and inferior horn of the thyroid cartilage. Get its name? The function of the muscle is to tighten the vocal cords. Hence, we use this muscle to sing alto. Mamma mia, mamma mia! The thyroarytenoid and vocalis are positioned superior to the lateral cricoarytenoid and pass from the thyroid cartilage to the arytenoid cartilage. Superior and most medial fibers are the vocalis. The thyroarytenoid loosens the cords, and the vocalis adjusts how much the vocal cords are allowed to vibrate. Mamma mia, mamma mia, mamma mia. Lateral cricoarytenoid extends from the superior border of the cricoid and the cricothyroid ligaments to the muscular processes of the arytenoid cartilages. They adduct the vocal cords. The transverse arytenoid unites the two arytenoid cartilages. They too adduct the vocal folds. The posterior cricoarytenoid arises from the posterior lamina of the cricoid and inserts into the muscular processes of the arytenoid cartilages. They abduct the vocal folds. This completes the naming of the muscles and the description of their actions. What is a good exercise now is suppose muscle groups in one slide that are responsible for opposite actions. For example, here we have the muscles that tighten and loosen the vocal folds. The cricothyroid tightens, the thyroarytenoid and vocalis loosen the cords. With respect to the sound that our vocal cords can make, think of a string instrument. If you tighten the string, the sound becomes higher. If you loosen the string, the sound becomes deeper, i.e., a violin versus a cello. And no, I will not sing again. For adduction, we have several, and they're listed here. The lateral cricoarytenoid and the transverse arytenoid. I do not list the opposite muscles because there is only one, the posterior cricoarytenoid. Hence, this is the only one that can keep your vocal cords apart and responsible for maintaining patency of the airway. Do you think it is important? Yes is the answer. Let me show you now what the vocal cords actually look like during phonation or speech. On the left image, in which they are partially adducted, versus how they appear during respiration, fully abducted. The frequency or pitch of voice is determined by changes in the length and tension of the vocal ligament, and this is a direct function of the muscles we just described. The quality of the voice, however, depends on the resonators above the larynx. For example, the pharynx, mouth, and paranasal sinuses. There will only be one Pavarotti or one Robert Plant because of normal variations in how the resonators develop and are treated by their respective owners. Let's now mention briefly some clinical considerations of the larynx and recall the few nerves we need to know: the recurrent laryngeal nerve, the external laryngeal nerve, and the internal laryngeal nerves, all indicated in the figure. As you recall, the thyroid gland is an endocrine gland which can become diseased and develop what is termed a goiter, a highly enlarged gland. If left unchecked, the gland will continue to grow and can become enormous. Look, for example, at the patient on the right, and it may shock you to know that even in this enlarged goiter pales in comparison to the potential size they can reach. Treatment is often surgical in nature, and herein is when knowledge of the disposition of the nerves becomes critical. Before removing the thyroid gland, its blood supply must be tied off, and due to the enlarged gland in such a small place, the recurrent laryngeal nerves are at risk when tying off the inferior thyroid arteries. The external laryngeal nerve is also at risk because the nerve is immediately deep to the superior thyroid artery. The outcomes of damaging one or both of these nerves are described here in the text. This now concludes the second portion of this lecture.